Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. We have a great guest on today, Nicole Bradberry. She is the founder and CEO of FLAACOs, the Florida ACO organization. Nicole, welcome to the program.
Thanks. Thanks for having me.
Awesome. I appreciate you taking the time to talk with the audience. So you are a underachiever. You are a health entrepreneur. You're involved in value-based care strategy, an investor, operating partner, board member. You are in it in the context of innovation and pushing the market forward. I think you need to do a little bit more, frankly. but I always appreciate attending the FLAACOs conference. To me, yes, it is a smaller conference, but to me, it's one of the most educational conferences you can go to because you can network. People are there to help teach, as well as just engage in how do we move this healthcare market forward. So I just want to applaud you on your efforts for FLAACOs.
See, I think it's got a unique vibe in that it is really people that come together to push value-based healthcare in the absence of fee-for-service. So it's really not about being competitive with each other. It's in being competitive against the old model of fee-for-service.
Yeah, I hear you. And we're going to talk about both of those models in a bit. So tell us a little bit about FLAACOs just in general so folks have a perspective.
Yeah, we've been doing FLAACOs for about 10 years. It started really right after the Affordable Care Act came out with the MSSP ACO model. And we thought, this is such a new model. It's a emerging space. And how do we get everybody together so that we can collaborate versus compete in this new, what we're now calling value-based healthcare. At the time, it was accountable care. And, it just kind of took off. It's, Florida is the most successful market in the country around these ACOs and value-based care models. A lot of that's because it's led by independent entrepreneurial docs and doesn't have some of the disincentives in other markets. But Florida uniquely, has been successful. But I think also they've done a really good job collaborating and partnering. And I think a lot of that has to do with FLAACOs and bringing everybody together early on. And so every year it goes a little bit bigger. We bring folks from all over the country to, help us be better. And as well as we have all the experts in Florida that are on our panels and continue to grow. And interesting enough, we're looking to build a TexCo in Texas later this year and have our first event there too. So I think there's a need for kind of state-based advocacy collaboration type models. And so we're going to experiment with number 2 in Texas. So, yeah.
Awesome. This market seems to be continuing to transition in many ways, certainly with the start of ACOs, and we still have 1.1 million providers that are still in this fee-for-service model. CMS established this objective to have all Medicare providers that are in a fee-for-service model into a risk-oriented contract by 2030. To me, that's going to spell a lot of transformation in how do these providers get comfortable with a risk-oriented model. I'm curious from your opinion on how that effort impacts in a positive way or a negative way the ACO organization, if you will.
Yeah, I would guess that 1.1 million. What's the total number of physicians in the country? Do you know? I don't know.
I hear different numbers, but the stat was 1.1 that are in a fee-for-service model today.
Yeah, because my guess is that they're probably still doing fee-for-service, but they're also in some kind of ACO or risk or shared savings model. Because, we have, 500,000 that are in ACOs, the Medicare fee-for-service ACOs. We also have, I would say, the providers in MA. Those models are emerging. So I would say that those are risk-bearing or they're taking some kind of risk in those. So I'm guessing there's a lot fewer that are exclusively fee-for-service. than we think. They're still doing fee for service, but they're also experimenting with some kind of version of a model, either a commercial payer model or Medicare, or et cetera.
Wouldn't you think that those individuals, that providers that are in a fee for service model today, not in any ACO, would have to join an ACO? I don't see an independent provider being able to take on risk, because their patient base typically will see more than one provider in and of itself. So to me, it would sound like it needs to be an organizational focus on that patient, not an individual provider focus on a individual
just
patient.
To take risk, you need you need numbers, right? And so the MSSP ACO model requires 5,000, just to get that bell curve to make a risk model work. They've got some of the reach models that go less than that, but they're kind of more experiments with the plan to grow. So my guess is, I just think there's fewer that are out there that are maybe in the middle of the country. But as you go to Florida and Texas and California and the Northeast, I would say most physicians are in some kind of model, and maybe the exceptions are the more rural areas. But and there's so many incentives to do it, because you get credit for your meaningful use, you get credit for your MIPS if you're in one of these models. Otherwise, you got to do it yourself. And just the work to do that says, why not be in one of these models? And then for primary care, you can almost double your income by participating in a successful ACO, because there's no other place for them to do that. And I think those docs that feel like they're on a hamster wheel participate in these models. And so if they're not in it, it's because they're either nearing retirement and they just don't want to do something new. It is my guess, with maybe some rural exceptions. So I think this path to value that started in 2012, I think every year more and more and more participants are there, and we know that it works. 51% of Medicare patients are in an MA plan. The other 49 are in a MSSP, and I would say more than half of those are in some kind of ACO. And just the numbers of patients that are involved tells you the number of providers that must be involved.
So from an ACO perspective, what would you say, not from an organizational perspective, but from the delivery of care mechanisms in order to achieve value? What would you say are like the top two pinnacle efforts that make an ACO, if you will?
Well, I think the number one thing is analytics, right? Because think about doctors, they're so busy every day, and they probably 99% of them still, even if they're part of an ACO, see the patients that present in front of them, see the patients that call them. And so what an ACO does, it takes all this data and it says, okay, here's our population of patients. Let me analyze them to think which of them should come in to see the doctor at what cadence. My unmanaged cardiac patients should probably come in every 3 months. My ones that are on 6 or more drugs, let's get them in for an evaluation. So the ACO does all that upfront analytics, and then even provides support. Either they, let the doctor and their staff know what patients need to come in, or they will actually sometimes put call centers in place and get the patients into the practice. And then the doc gets to do what he does. And typically docs do the right thing. What they don't do is outreach and proactively go out to patients who need to come in. So I think analytics is the number one thing that ACOs do. And then number two is all of that support. Do we help them with the outreach to get patients in? Do we provide some care management? Do we provide some care coordination in addition to the staff that the doctors have? And so I think those are the two probably biggest things.
Where do you find patient engagement in that ecosystem, and the importance of that?
So the reason value-based healthcare exists is because of patient engagement. So the payers who tried to do it through utilization management, disease management, failed, not because they didn't have sophisticated programs, not because they didn't have smart people and great ways to think about it, but the fact that they could never get past a 10, 11, 12% engagement. And so in order to change that shift and really, because they cared about bringing the cost of care down because of lots of reasons, mostly because of market share loss. People couldn't afford insurance anymore. But anyway, they, delegated what we call medical cost management. So you have two things within insurance. You have the insurance risk that actuaries worry about, and you have medical cost management. The difference is the person that steps off the curb and get hit by a car versus the person who has unmanaged diabetes, right? Only the providers can really manage that unmanaged diabetes payers tried, but they could never hurdle that 12% engagement. And so just by shifting that to the providers and to ACOs, we've got an average about 50% engagement, which is huge, 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 huge. And also these doctors touch their patients hopefully at least once a year, whereas the payers are all doing this predictive analytics to try to just get to 5 or 10% of them max, and see what they can do. And so it's just a whole different game, but engagement is the reason. And you have to engage patients in order to shift cost and quality.
Oh, I'm a believer that every patient is on this, what I refer to as the awareness to wellness continuum. And patient engagement increases awareness. Outside, you might have gone to your doctor and now you're aware you're a diabetic. And so how do I fix that? So education, the engagement raises education, raises behavioral change, and all, forward motion towards a better path to wellness. I'm a believer that, and I have a big background in diabetes with my father, but
well, there's a great saying: patient engagement is the next blockbuster drug, right?
Yeah, exactly.
As powerful as
I agree.
Lipitor was, engagement.
I'm with you 100%. 70% of all chronic conditions are based on behaviors, right? So at the end of the day, you need patient engagement. So the story with my father, my audience well knows, is he was obese. He had dialysis at home, and he just never listened to his doctors, right? Even though he went twice a year or three times a year. But at the end, and diabetes doesn't hurt. So if it doesn't hurt, I ain't doing anything, right? That's some of the attitudes, all right? But in the last 5 years, you lost one leg, second leg, an arm, and 2 fingers. So diabetes will hurt. And then there's this transformation of the home. Dining room becomes a bedroom, add a second downstairs bathroom. I always said my mother was lucky she had 6 kids because she had 6 additional caregivers to help in that context.
He's lucky, yeah.
He's lucky. He was lucky. So where do you think services like remote monitoring and chronic care management and things of that, therapeutic monitoring, where do you think that plays a role in patient engagement and ultimately the success of an ACO?
Well, I kind of see them as a bridge. You had the old fee-for-service models, and you have the whole full risk models. Under full risk, they should be doing all that stuff because they know it moves the needle. Well, they couldn't quite get physicians to move from one to the other without some kind of bridge. And the bridge were what I call these value CPT codes that rewarded the behavior that is needed to take on risk and take on medical cost management. And so they had to figure out a mechanism in the old fee-for-service world to pay for these new activities that doctors weren't doing. And that's what those codes are. You've got AWV, you've got CCM, you've got RPM, and there's a whole slew of them that have come out. But they really reward that. They pay for that behavior that we know moves the needle on the back end for cost and quality. And so as you shift all the way to at-risk models, you shouldn't need them anymore because all of those behaviors should already be incorporated in the risk dollars. But, RPM is just a way to get intel real time when patients are at home. I mean, you need that, right? You can't wait for that twice a year visit to figure out what's going on with patients who have severe chronic disease.
Exactly.
And so, they play a very valuable role, but how do you get doctors to start using them is really where I say these codes that came in are the bridge. So.
No, I agree. It is the bridge. And if a provider that needs to move to value, to me, you mentioned it earlier, provider today, they say, hey, in my practice, I need to make more money in 2024, and they're a fee-for-service model. The natural reaction is to tread faster on the hamster wheel. I hate to say it that way, but that's the truth, right? So on the flip side of that, to get the experience and understand what risks they can take and they can't take is these value-based, these virtual programs, remote monitoring, chronic care management, you named them, they provide that intel. It's all about the data, right? So I am, and I agree. Once they have patients on there for 1-2 years, they now understand how to manage risk because they have the data to support them.
Exactly.
To your point, analytics is key, right?
They had the incentive to do things they wouldn't normally do without that incentive, which gave them data that they didn't have before that shows them how successful they are. And it's just a pathway kind of to taking risk and being successful in risk models. So, and are all the right things.
So what can we do more to educate physicians on this pathway? Because to some degree, Florida might be different because there is FLAACO and they do a great job, as I said. But educating the physician on this path to value, I don't think that there's a national strategy, if you will. The objective is everybody's on risk-oriented contracts by 2030, but I don't know if we have a unified strategy
Well,
on
I think I
providers.
would follow the incentives. I think that, the reason Florida is so successful is you did have an MA kind of market there that was used to a little bit of risk, but you also had all these independent entrepreneurial doctors that didn't have all the disincentives that exist within the hospital system. Does the hospital really want to reduce hospitalizations, which is the number one area to find cost savings? And it's actually better quality if a patient's not in the hospital. And so if you go market by market by market, you'll see the difference is when you have a very strong hospital market. I'm not dinging hospitals, but
No,
when you have
I know you're not.
they're just the incentives, it's kind of the
Yeah.
system, not the people that are part of it. But in those markets that are led heavily by hospitals, they might have put their toe in the ACO and the value-based healthcare world, but at the end of the day, their physician health organizations aren't incented the same way. They're incented for leakage, not for moving the needle down. And so until you can right size all those incentives, you're not going to get the embracement that you have like in Florida and some other markets for value-based healthcare, because the money isn't trickling down. And I hate to say it, but doctors run small businesses. And so at the end of the day, you have to align the incentives. That's why we have a hamster wheel, is because the incentives for fee for service is do more, do more, do more. Value-based healthcare is do the right stuff and probably do less. And so you have to move those incentives to get people to really change. And so the markets that right size them, like Florida, versus the markets that don't, and there's many of them, I think are lagging behind. And you can see it just in the success on the overarching savings numbers. And then you have this whole swath of the country that I think, it's just getting there. They're just late to adopt it, but it's happening because at the end of the day, when we started down this path in 2012, 2013, I'd say the hospitals had about 80%, and don't quote me on that number, but a big, large chunk of the pie of cost, of dollars that went to the health system, health provider system. And so as you're seeing these risk models and markets be more successful, that pie is switching and rewarding more of this upfront care, this proactive preventive care. And that's the way it should go. But, if you have lots of strong, forces in the marketplace that are keeping that from happening, it's just going to take longer.
Yeah, that's fair. And I think one of the challenges that hospitals have, and I'm not digging them either. I'm all interested in how do we get everybody to move together as opposed to individually, because we can create a much greater inertia where everybody wins if we're moving it together. But a hospital needs to, because they operate on very, very thin margins, as you know. So any incentives that they have to cover their financial risk as they move, right? So right now they love high utilization of bed count because that's what makes them money. So the idea that, hey, I don't want to have a high utilization of bed count, I need to make sure my financials are still stable, right? Because if you don't come into my hospital, I don't necessarily make a lot of money. It's the ambulatory side of the equation.
And there's such a great story there. If you move $1 to the physician health organization and look at the hospital as an operating cost, it's just a completely different perspective. But they're not doing that because revenue one is when they fill a bed. But if you move it back, then all of a sudden ACOs and value-based healthcare makes sense, and so it's really a total shift in how they perceive their revenue and what then becomes a cost. You have all these hospital buildings. We probably have too many in this country. And maybe, as our growing aging population, we think about using that real estate for long-term care and things like that we know we need. And it's just a shift in the business model that has to happen. And, when I was consulting with hospital execs, early on when this was all happening, I'd say, do you want to be Blockbuster or do you want to be Netflix? And it really was a complete shift in the business model, right? And they're still holding on to that real estate and filling beds. And they really have to make a fundamental shift in their business model in order to embrace value-based care. And so it's just a hard thing to do.
So we're in 2024. Regulations are still changing. ACOs certainly are growing. We have this 2030 objective. What do you think are some of the inhibitors to growth on an ACO front?
Well, I think I just talked about the biggest one. It's just that business model shift from hospitals that dominate, large marketplaces in this country. I do think some of the things that are helping is this shift to hospital at home care. It's taking away from that need to be in a bed in a hospital. I think policy, certainly, and there's a lot of, think about the reason margins are so small in the hospitals is because of all the things that they have to pay for that are just egregiously higher than if it was more of a direct to consumer business, right?
Right.
And so the fact that it's not a direct to consumer business, it just falsely elevates every single cost along the way. And so there's some things called value-based purchasing that are hopefully coming in to bring more right size to cost of devices and things that the hospitals use. The staffing is a huge issue, and so I think because of that might actually be a benefit to value-based healthcare, because hospitals and healthcare organizations are struggling to get the staff to keep everything running the way it has historically run. So creative ways of virtual care, virtual primary care, the shift to home, all of that is coming in, and I think it all lends itself to this movement of you will get better outcomes, lower cost of care altogether, if you embrace value-based healthcare. I think one of the other things is you've got MA and fee-for-service kind of competing. The fact that MA is 51% and what just 8, 9, 10 years ago was 18% of the patients in this country. And it's higher. It costs more. It costs more than fee-for-service. The whole point of MA was to be cheaper, right? And their argument to that is that, well, our patients are sicker. Well, I would counter that with probably they've just been risk coded sicker, because that's where, MA has historically managed the revenue side versus the move the needle side. And so I think as long as MA continues to grow, I think some of these more creative models, around fee for service to moving to at risk where providers are in charge, I think are not going to move as fast as if we go to more the payer delegated risk models on the MA side. But I'm hoping that these models converge, and at the end of the day, we can call them all value-based healthcare.
Yeah. And you talked about data, the use of data earlier. I'm concerned. When I asked about what are some of the changes needed, I was thinking more from a regulatory perspective. But that said, I'm sure you've seen the numbers as well. There was a report out earlier this week that in 2024 there's a 5% growth in federal spending on healthcare, right? That's as well. You also see there's more people with diabetes today than yesterday, more people with cardio problems today than yesterday. I think because we don't have this unified strategy and everybody's embraced value, that we're losing the war, if you will. I hate to say it that way, but we're losing the battle in the context of the true mantra of value-based care: increased quality of care, better outcomes, reduce costs, right?
Well, and I think, at the end of the day, the whole point was to make healthcare less a percent of the GDP than it was when we started, right? And that has just not happened. So that means that, policies and all of these things that have gone into place has really moved the needle up. It's because we've rewarded risk coding. On the ACO side, at least put a cap on it. On the MA side, there's been no cap, but we've been rewarding all these things that do we really have more cardiac patients? Do we really have more diabetics, or just are we really good at risk coding where we weren't in the past because we weren't incented to do it? And it's all of those things. But at the end of the day, percent of GDP is higher than it was, and that is not good. And I'll throw that I think, what I love seeing that's happening in healthcare is this push to engagement, food as medicine, lifestyle, all of this stuff, get away from just diagnose and prescribe, diagnose and operate, and let's get back to root cause healthcare. If we really want to make that shift and better outcomes
Absolutely.
and lower costs, you got to go there, and you have to start looking at why people are getting sick and fix that.
Yeah, I had a guest on a couple of months ago. He was a civil rights leader actually, and he talked about the urban community. Doctor says, hey, you got to go on a diet. You got to lose some weight. But the neighborhood deli has 66 different flavors of beer, but they don't have apples and oranges, tomatoes and lettuce, right?
Right.
So it's tough for me to get that. I want to, but access to are two different things, right? And I am absolutely with you. It's not about taking that pill, because the pill is a maintenance dose, in my opinion, and we need to.
It doesn't cure anything.
It doesn't cure it. That's
right.
what I meant by a maintenance dose.
Yeah.
So it doesn't cure anything. Just because you have diabetes doesn't mean you have to die with it, right? It's not about managing diabetes. It's about putting it in remission. There's a way different headset that you need in order to change behaviors, and you got to do it collectively, right? I remember, I hate to say this, but I was a wrestler in high school, and I cut weight like there was no tomorrow. But when you have a family of 8 sitting at the dinner table, which I always had to sit at, and they're all eating, and I'm not, and I'm having Jello, right?
The point,
yeah, it's not fun. But the point is that a person with diabetes, they're on a diet. Everybody's got to be on a diet in that household.
And you know what? And we shouldn't even look at it as a diet; as more of a lifestyle change.
Yeah, that's a great point.
It's really it's the quality of our food. It's with the food we choose to eat. It's less processed, less fast food. It's really you should be able to eat as much as you want if you're eating the right stuff. And back to kind of change. I mean, even Alzheimer's right now is now being called diabetes 3 because they believe that it's truly a lifestyle. Food is medicine type of cure. And if we can just get and focus on that, we can, how many people are suffering from Alzheimer's and how many more do we predict? It's huge if we can get back to root cause and solve that. And back to your kind of the food desert issue, what's more health? What is health equity? It's not really DEI and all the things that we're hearing. It's how do we make sure there is healthy food in every supermarket that is affordable for everybody? That's true health equity. And how
Absolutely.
do we, and understanding that is engagement, right? If we understand what people are struggling with at home in their neighborhoods and solve for that, that's the real engagement and come up with real solutions. And so, and that's, I think we get sidetracked with the buzzword of health equity and not really understand what it means to give everybody the same health equity. It's things like that.
Grassroots. Nicole, I'm going to have to leave it there. You just nailed it. I'm absolutely aligned with your thinking there. With that, I want to thank you again for joining the program, and hopefully we'll have you on again soon.
Yeah, thanks for having me.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.